Hello, everyone. My name is Brenda Scott, and I am with NAMI Mount San Jacinto. And we thank you for joining us today. Today we have Dr. Ijeaku, and she is a board-certified child, adolescent, and adult psychiatrist serving in various settings with Riverside University Health System and UC Riverside School of Medicine. Within the Riverside County system, she caters to a population that is under-resourced and underserved and whose health challenges are often complicated by various psychosocial factors. Her clinical practice includes working closely with psychiatrists and other physicians, therapists, parent partners, and community advocates to help address the underlying psychosocial issues affecting the vulnerable patient population. As a site director for the Child Psychiatry Rotation at UC Riverside General Psychiatry Residency Program, Dr. Ijeaku's primary duties include designing an appropriate pediatric psychiatric program for the residents in outpatient and inpatient settings to prepare them to deal with mental health issues affecting pediatric patients. Dr. Ijeaku also serves as a board member of NAMI Mount San Jacinto. And thank you, Dr. Ijeaku, for joining us.
Thank you very much, Brenda. And good evening, everyone. Welcome to our community-based talk this evening on Tardive. So Brenda, if you can put it up so we can just get this going.
Mhm.
Oh, actually, I can move this, right? I can move it along. Can I move it along since I'm a co-host?
I don't think so.
Oh, I can't. Okay. Okay, so yeah, let's so that's me. My primary practice, like she said, is within the county, but I'm also associate professor at UCR School of Medicine. Brenda? Okay, and I have no financial interest or relationship to the report, and I do not intend to reference unlabeled or unapproved use of drugs or products in this presentation. So I'm hoping that at the end of this talk, we'll be able to at least list basic mechanisms that underlie the developmental dyskinesia. I'm also hopeful that we'll be able to list some of the risk factors that could lead to that condition, and that we might be able to list some talking points that we can use against stigma that is related to TD. So Tardive dyskinesia, the shortened form of it is TD, so I'll use that a lot during this presentation. So I'm gonna have us check in, see what we know about this condition. So this is really pretty chill, not a big deal. So just to get, how many patients on typical psychotropic medications and how many on atypical antipsychotics have TD? So let's make this fun. What do people think?
Should we put it in the chat or just say it out loud?
Yeah, no, say it. I want this to be interactive.
Okay.
Okay, B. So Claudia thinks B. Okay. Anyone else?
I'll say A.
Say A, okay. Julie, you're trying to say something, but you're muted.
I'm completely unfamiliar with tardive dyskinesia, so I could only guess. It'd be a wild guess.
So it's a guess, huh?
So C.
C. Okay. So you and Claudia just chose opposites. Anyone else want to take a guess? Okay, so I don't know how many of you are familiar with the typical psychotropic medications. So those would be like the Haldol, the chlorpromazine, so the older psychotropic medications. And then the atypicals are the Rispedols and Zyprexa and Seroquel, so the newer ones. So TD is more notorious with the older ones, right? So it's either A or B. Couldn't be C or D, right? Because it's the older ones that are more. However, the literature that I was looking at actually said is a 3-to-1. So it's a 32%, 13%. So the A is the correct answer. So it's a 3 times increased risk that you get with the older psychotropics compared to the newer ones. Yeah. Okay, awesome. So moving on to the next. And then what is the percentage of patients that completely stop their psychotropic medication use due to concerns for tardive dyskinesia?
I'll say C.
C, okay. So I think we have 2 C's now. Anyone else?
I'll say A.
A, okay. So Claudia says it's Adderall one of them. So Adderall is not one of the notorious ones. Adderall has its own peculiar issue, but it's not one of the notorious ones with this condition, the TD. Okay, so I have a 48.4 and I have a 55.6%. So the answer actually based on the literature that I looked at is 39.3%. So almost 40% of people, 2/5 of those who take their medications would discontinue because of concerns for TD. And I think that's a lot, 40%, that's a whole lot. So it's a big deal. Okay. So this was a poster presentation at Psych Congress, but what percentage of patients with TD reported their illness as having a severe impact across their physical, psychological, and social lives?
I'm gonna say A.
A, okay.
I'll guess that too, because I'm hoping it's no higher.
Yeah. I'm gonna go with A too.
Okay.
I will go with C.
C. Okay, who went with C? Is that Carla?
Yes.
Okay, so that's the answer actually, C. So 75% of people, right? Like 75% of people that have TD report a severe, like this is not just an impact. I thought that was huge, right? So severe impact across those domains of their lives. So big deal. Really big deal. So TD is a treatable disorder, true or false?
True.
I think that adds it. It says that it can be treated, but does it cure it? I think it can be treated.
Yeah, I'm going to say that too, because I think once a person gets it, it's hard to get rid of, is what I've heard, but I'm not sure.
Okay.
Also true.
So yeah, so it is treatable. It is a treatable disorder. Okay, and then the last question is, and what neurotransmitter has been implicated the most in the development of TD?
I'll say dopamine.
Okay.
I'm saying GABA.
GABA. Okay.
Well, I'll go with
I say
Dopamine.
I'll go with C. GABA.
GABA. Okay. So many theories are bound, as with a lot of things that we have within psychiatry, or things that happen in the brain, right? Because the brain is too complex for some of the ways that we look at it. But the neurotransmitter that has been implicated the most is definitely dopamine. So, and you will see later on, even the treatment options that we have now, stem from that, and the theory of how it develops also stems from that. So, okay, so awesome. Let's move on to so as far as the background goes, I wanted this seesaw arrangement to sort of bring home the relationship between dopamine and acetylcholine. So those are two major systems that control movement within the body, within the brain. And they sort of go in that fashion, right? So, so if you kind of think about that with some of the things that we're going to review. So movement involves an equilibrium in a certain part of the brain that is called the dorsal striatum, and it really is the major system. So looking at dopamine and acetylcholine. And so the medications that we use in psychiatry can mess up that equilibrium and throw things into jeopardy. Okay, so yeah, so just kind of thinking about that seesaw. Sometimes our medications will mess that up. And that's why we have some of these movement issues. So what is TD? What is tardive dyskinesia? So tardive refers to the slow onset of involuntary movements of the face, the lips, the tongue, the trunk, the extremities. And then dyskinesia refers to the involuntary muscle movements that can range from a slight tremor to just whole uncontrollable movement of the body. So there we have involuntary movements and repetitive in nature. So we commonly will see this in individuals who are on a long-term treatment with antipsychotic medications. So it is unlikely that someone who just started their medication like a week ago or a month ago should develop tardive dyskinesia. They could develop other types of movement disorders, but the specific movement disorder that's known as TD is unlikely. So, but movement disorders that are related to psychotropic medication use, again, if you think of that seesaw, are typically secondary to that imbalance that some of those medications we prescribe will cause. So that's what brings about some of the movement disorders. So what we normally call EPS, extra conditions of dystonia, Parkinsonism. So these are other movement disorders. That's not tardive. So remember that tardive dyskinesia is a type of movement disorder that we can see with our psychotropic medications, but it's usually with long-term use and is a very specific way. It's slow, it's involuntary, can range from a little tremor to like a whole big movement of like say the trunk. But we do have other types of movement disorders that we just typically call extrapyramidal conditions, like dystonia, like we could have like, someone has like the stiffening with the neck or with the arm, the rigidity, or the Parkinsonism, where there's just like the flat of movements. They almost look like they have Parkinson's. And those usually happen because our medications, remember those medications, whether it's a typical, which is like the first generation antipsychotics like Haldol or chlorpromazine, and the newer ones, the atypicals like the Zyprexa, the clozapine, Seroquel, Risperdal. The target of these psychotropic medications, so those medications that we call antipsychotics, which help with the hallucinations, psychosis, agitation, aggression, those medications. The primary mechanism is that they block dopamine receptors, because the idea is that in those conditions, with these hallucinations, the delusions, that there is an overdrive of dopamine. So we block dopamine receptors to get the effects that we're looking for. But remember, if you remember the first picture of the seesaw, so if we block dopamine, we throw acetyl, to look a certain way. So it appears that acetylcholine is relatively higher than the dopamine because we block dopamine receptors. So that is the usual stuff that happens in the other types of movement disorders that we see with the patients that we have prescribed our medications to. So, Brenda, can you move? Okay, so with those types of conditions, we could use what we would call anticholinergics like Benadryl, like Cogentin. So if you notice, some of the individuals on antipsychotics are automatically placed on Cogentin so that we don't have those extrapyramidal effects that we know can happen. But again, that is just because of an imbalance, because you're blocking dopamine receptors, so it appears that there's an overpowering of the system by acetylcholine. So we treat those conditions typically by using anticholinergics, right? Benadryl, Cogentin. So that's those extrapyramidal movements. But tardive is usually seen in individuals who have been on an antipsychotic for a long time. And the idea is that because you have blocked dopamine receptors for so long, that the dopamine receptors have become super sensitive, and our body attempts to sort of offset what we're doing with the medications by upregulating receptors. So you have many more receptors, basically. So what is happening is that that upregulation that has happened because we've had a long, prolonged blockade of the dopamine receptors causes that exaggerated effect that we see in Tardive, right? So because the dopamine receptors are super sensitive, that's why you have all that exaggerated movement that we see downline, okay? Brenda? Okay, so TD, super sensitive neuron. So it's not just a shift in that equilibrium of the seesaw, which is what you have in the other types of movement disorders that you can have with the medications that we prescribe. So that's why in Tardive, if you use the typical medication that we would use for the other movement issues, it will not work. So antipsychotics bring about the imbalance. And because there's a relative overpowering of that system by anticholinergics, by the cholinergic system, if we want to treat EPS, the usual EPS, we can use anticholinergics. But in Tardive, we cannot, because the process there's been a long-term blockade of dopamine, and there's super sensitive neuron, and it's upregulated, and like the movement is uncontrollable as a result of that. So the mechanisms are different. So the treatments are different. Okay. So I would like, Brenda is going to play a video so we see what Tardive might look like.
Just a second here. I just have to bring this up. Whoop.
Just one or two quick things. Maybe put your hands out like this. And then relax.
Ooh.
Did we lose connection? I'm not hearing anything. Can you guys hear me?
Yeah, we can hear you.
Oh, okay, okay.
Yeah, I'm waiting on Brenda to put the.
Oh, okay, okay, sorry.
What did you guys think? What did you think about the video that you just saw?
I was looking at it thinking sometimes you see some of the homeless people and they look like they have those same involuntary moves, and I wonder if it's associated. I think it's sad.
Mm-hmm. Okay, so this is a checklist that is prepared by the person who did that assessment of the video that we saw. So just, looking at it, the blinking, the wrinkling in their brow, looking at facial movements, neck and trunk movements, as well as movements in the extremities. So this person's really hit, they really hit really bad. Like they have it really bad. But what I also wanted us to look at is the movement disorders that I talked about earlier, right? I mentioned how TD is like a very specific type of movement disorder, but we do have other types of movement disorders that can still happen when people take antipsychotics. So Parkinsonism is just, if you're familiar with, people that have Parkinson's disease, like how they're like really slowed and all that. So we can also have it with like antipsychotics. It's a different process from TD. So this tries to look at how we would want to make a case for this, how this is TD versus like a Parkinsonism because of what we saw, right? Like we saw increased blinking versus like decreased blinking. So like in Parkinsonism, movements are decreased, like there's just a lot of decrease. So if you can look, so this tries to make, sort of look at that comparison. So just because someone has like movement issues, abnormal movements, and especially if we can make a connection between it and the psychotropic medication they take, we still have to do a lot more evaluation to try to determine what type of movement disorder, because like I've mentioned in the last few slides, the treatment is entirely different because the causes are different, right? So TD, which is our topic for today, is because of long-term use of antipsychotics, leading to an upregulation of dopamine receptors. So they're super sensitive. So movements we see are more like what we saw with that lady. Of course, hers is pretty major, but because sometimes it doesn't have to be as bad as what we saw. It could be like just like lip smacking or something like that. It could be, doesn't have to be as severe as what we just saw. But we can also see other movement disorders. Just want to be clear, I want to keep emphasizing that tardive dyskinesia is just one specific type of movement disorder that we see with antipsychotics. We have a whole lot that happens that has nothing to do with TD. Okay. Okay, Brenda. So it has so TD has an annual incidence of about 2 to 5%, and so it occurs in about 15 to 30%. So perhaps up to about a third of those who would require long-term treatment with antipsychotic medications. And this would typically, we know this, right? This would typically be like people that have schizophrenia, maybe bipolar disorder. So our severely mentally, the severe mentally ill people are the ones who are more likely to be on long-term treatment with antipsychotic medications. So up to about one third of them may have, could develop TD. So it's so important that we look into this. And another important point that I want to bring up is there's been some statistics showing that even though, say, something like Risperdal is an antipsychotic, the most of its use at the current time is not necessarily in individuals that have schizophrenia or bipolar disorder, right? We use it a lot in people that may have like agitation, like intellectually disabled individuals, autistic individuals, even people sometimes who have anxiety, but just like, and it borders on like psychotic experiences. We use Risperdal, we use Seroquel, we use even Zyprexa sometimes. We use it quite a bit outside of what we would typically call the severe mental illness. So that also brings up the idea that we are beginning to use, especially the second generation antipsychotics, the Risperdals and the Seroquels, we're beginning to use them a lot in individuals who do not necessarily have like schizophrenia or bipolar disorder. So it's not so much the diagnosis you have, it's about the long-term use with those antipsychotics that could predispose you to developing TD. And we've just mentioned now that up to about a third of people could have it. So the question that I had asked, that's the next point, which is that is about a 3-to-1 ratio when you compare first generation to second generation antipsychotics. And then individuals who previously developed acute adverse side effects to dopamine antagonists are more likely to develop TD, right? So if you had like an acute dystonia, so this could be like within the first 1 or 2 days of taking the medication, someone suddenly notices that their neck feels weird and it's like in a weird shape, and they had to get on Cogentin, people like that may just have more sensitivity to certain medications and may be more likely to develop TD in the long run. Okay, next one, Breno. So like I had mentioned earlier when I asked you guys the question about the neurotransmitter, there's no really universally accepted theory and mechanism, but the major theory really points to dopamine. But GABA and the cholinergic deficiency, oxidative stress, or just kind of trauma and things like that, difficulty or altered plasticity within the brain, neurotoxins, like any of these concepts have been hypothesized as being possible ways that TD occurs. But the most influential working hypothesis is it involves the dopamine system. And again, the medications that we use, the antipsychotics, are also developed based on the dopamine system and its blockade of dopamine system. So that is the most implicated neurotransmitter for TD. So the number one risk factor for a psychotropic medication induced TD is definitely use of typical and atypical antipsychotic medications. Older age, being female, and that is thought to be perhaps due to the fact that estrogen may be protective. So, in postmenopausal females, previous brain injury, so one who's had like a TBI or somebody who has dementia, and just in general, when somebody has something else going on, the teaching is just to take it easy with medications, right? So if somebody were seeing me for the first time and they have like autism or they have even intellectual disability, I'm starting them on medication. I'm not just going to use regular guidelines for their age, for their weight. So even if they are kids, I tend to start lower because we know that their brains are just a little more sensitive. So just being aware of things like that. And like I just mentioned, that if you've had extrapyramidal symptoms like dystonia, Parkinsonism, things like that in the past, you're more likely to develop TD. And then people of African and Africa are also tend to be of higher risk of developing TD. Next. So TD is not a psychiatric disorder, right? It is neurological. So when you have a movement disorder, it's neurological. The only thing is that our psychiatric medications could cause TD, right? So it's a movement disorder. It can be negatively impactful, like we shared earlier on. About 75% of people that have it talk about all the burden psychologically and physically and socially. And TD is preventable, and TD is treatable. So just a few more points with the disability and stigma. So the point is to encourage someone who does have a need to be on psychotropic medication to stay on their psychotropic medication. The other point is to work with somebody who is willing to work with you and your concerns. So if you were to have a side effect, you first got on the medication, it would mean that the person who's treating you should be more careful in how they are monitoring you for the development of like a TD. So if somebody were just having like this lip smacking or like something really maybe simple like that, like it's like very barely noticeable. If one is paying close attention, is doing evaluations, really looking for abnormal involuntary movement on a regular basis, because that individual is on a medication that they did have issues when they first got on the medication, then you can diagnose it early and you can put them on medication versus waiting till we're at the level of that lady that we saw the video where it would be difficult to convince someone like that to stay on their medication, and yet they still need to be on their medication, right? Because if you got off the medication, it really doesn't mean it's going to reverse. And yet you could still have like the psychosis and the bipolar and all of that come back and just make things a little more complicated for that person. So it's important to just think about the fact that it is preventable, it is treatable, and we really want to make sure that people are not carrying extra burdens related to stigma with that condition. Brenda, sorry, yes, thank you. So psychoeducation of patient and family about abnormal involuntary movement is really important at the first time at the initial evaluation. And starting from the initial evaluation, one needs to do what we call an abnormal involuntary movement scale and do it, very frequently. And then ask patient and family about abnormal movements, take them seriously. If you're having difficulty trying to figure out what it is, you could always send them to a neurologist to help figure out which one it is if you're having issues. And then you also want to make sure that you have detailed history and examination so that you can tease out whether you're dealing with a TD or a different type of movement disorder, because as we stated over and over, the treatments are different. So we have something that is called an MIND. So it's those acronyms like, do you see abnormal movements, impact on your life? Is it noticed by other people? Do you have daily activities affected by it? So this is a new material or scale that was developed by the same people who put up that video, just as a good guidance to help in how we make our diagnosis. Movement, so this is questions for the patient. Do you notice any movement? Has it impacted your life in any way? Is it noticed by other people? Are your daily activities affected by it? So, if you pick up any of this, then you want to move on to the next one. And so if they have yes to those questions, you move through this. So you want to do like a thorough interview about their eating, their swallowing, just all types of movements that they have. So if you haven't even elicited any movements, you can, like that guy asked how to stretch out her hands. You can have that person maybe say like consonant sounds like camel, things like that, just to see if you pick any abnormal sounds, even just to help you. Have them walk, see if they are grinding their teeth. Do they suddenly have sores they can explain, things like that. But the idea is just to be very thorough in your evaluation of patients. So if a patient is on those medications, you don't just keep handing out more medications. You have to be very on point with the questions you're asking. And if you got any of those yeses from the previous slide, you make sure you do more of this. And then you try to differentiate, am I dealing with a Tardive dyskinesia or am I dealing with a different type of movement disorder? Because again, treatment is different. And so according to the DSM-5, so Tardive dyskinesia is a medication-induced movement disorder that can develop after short-term and long-term use of medication, as well as after change or reduction in medications. So it has to persist for at least 1 month after the medication is discontinued to make a TD diagnosis. So while it is helpful in helping us diagnose like dopamine antagonist-related TD, it falls short of the wide range of medications that can also cause TD. Some people have mentioned, lithium, which as far as we know has no basis with like dopamine. But I think that a lot of the times that people will mention having like TD, maybe they forget there was a history sometime in the past, or we don't get good histories. But other medications can cause other things. But as far as TD goes, the typical medication that causes it is psychotropic medications. But of course, there'll be reports of, somebody was on Prozac and then they kind of developed a certain movement disorder, so. Okay, next one.
Did you say Prozac can cause the movement disorder or not?
No, I mean, the typical cause of TD is an antipsychotic. But I'm saying that there are times, but it be someone on a stimulant or on an SSRI, there are people in other, taking other classes of medications who might report what's happening. And I think that a lot of times we don't necessarily take the time to do the evaluation, do like a detailed history. Maybe we may find, they used to be on like a Risperdal like 3 years ago, but they're not considering it because they're not on it right now, or they might be on other medications, so it's just like highly unlikely that the other classes would cause it, but it's important to be aware that medications, different classes of medications can cause different types of movement issues. Now we want to consider maybe discontinuation of that medication that is causing it. We may want to consider use of the second generation antipsychotics. Remember how we said that is a 3-to-1 ratio of how bad they could affect or lead to development of TD. So we may want to consider using like a second generation antipsychotic instead of the first generation antipsychotic. And we may also want to consider medications that would slow the process of that upregulation. Remember how I talked about how the movement disorders that are not the non-TD movement disorders are caused by overwhelming of that equilibrium, the seesaw of the colon, right? But Tardive TD is caused by upregulation of dopamine. So one mechanism to treat it could be to block or to process that that allows further release of dopamine, right? Because dopamine receptors are pretty sensitive. So we don't want a process that is going to even make that process worse or cause release of dopamine, because the receptors are just like super sensitive, just waiting. Any little dopamine, acts really out of whack. So that's the problem in TD. So the treatment, right? So if you think about, so dopamine is packaged in like little vesicles, like little sacks dopamine gets into those little sacks, sort of their storage sacks, by what we call the vesicular monoamine transporter type 2. So any process that decreases the amount of dopamine in each vesicle would reduce the amount of dopamine that is released down the line, right? And so most of the two medications that are currently FDA approved use this process. So the dopamine is released into the brain, does what it does, and then it gets transported back, like it's mopped up and put back into like little bags. And the packaging into those little bags is by a transporter system that's called VMAT2. So these medications primarily will block, so those inhibitors, like anything that inhibits that transport system does not allow too much like dopamine in those little sacks. So there's nothing to be released to cause the issues. Okay, and some of the other medications that people have used in the past include benzos and beta blockers. So early in 2017, so just 2017, FDA approved a new medication for the treatment of TD with the trade name Ijeaku and generic name valbenazine. So this medication was fast-tracked by the FDA, given the fact that at the time, so if we had this talk and I said TD is a treatable disorder, false would have been the answer. So at the time, TD was considered not treatable, and the clinical trial that led to the approval evaluated the movement of 234 individuals with TD who were also diagnosed with schizophrenia, schizoaffective disorder, bipolar disorder. So again, our severe SMIs, right? That's who is more likely to have TD because they have to be on medications long-term. So these research subjects were randomly assigned valbenazine or placebo, basically a sugar pill. At 6 weeks, a clear difference emerged in the movement symptoms of the two groups, which led to the approval. So this is how FDA got to that point with that medication. So for Ijeaku or valbenazine. And then the second one that got the approval has the trade name of Austedo, and is the generic name is tetrabenazine approved so earlier in 2017 for the treatment of chorea. So chorea is kind of the dancing movement. We see that a lot like in neurological condition where people call it chorea is like dancing, which you see with Huntington's disease. So the second indication approval was based on results from 2 randomized controlled group studies that found oscillatory so do tetrabenazine to be effective and safe in reducing the severity of abnormal involuntary movements associated with TD. Okay, so again, these 2 medications came, from 2017 moving forward. That's when we had this new FDA-approved medication. And also notice how both medications are based off of that dopamine system that is upregulated, super sensitive. So these medications, their primary job is to keep dopamine away from those super sensitive receptors, basically. That's the way to think about it. So how do we prevent TD? So given the impact of TD, 75% of people say it's severely impactful in a negative way. Prevention is the best method to avoid it. However, use of TD-causing medications may be unavoidable. So if you have bipolar disorder, you have schizoaffective disorder, you have schizophrenia, or even for some of the ones that we're using now, intermittent explosive disorder, in autism, intellectual disability, people who have a lot of agitation and aggression. It really has nothing to do with the dose. So even with people on low dose, say Risperdal 0.25, 0.5 on a daily basis, 2 years, 3 years, 4 years, we're becoming long-term, and we expose them to the risk of TD. So we want to really be very careful about who we start on this medication. So we have to discuss this risk with our patients. We have to also see about what happens when we start them on medication. Do they develop other types of movement disorders? Because if they do, that means they're more likely to develop TD. That means we have to be extra careful and be more vigilant in our follow-up evaluations. So we should try to prescribe the lowest possible dose of a medication, and we should try to go for medications that are least associated with TB. So unless someone absolutely has to be on like Haldol or any of the medications in that class, we're safer off with the 2nd generation antipsychotics. Now, the 2nd generation antipsychotics, the Zyprexa and the Zyprexa, Seroquel, Risperdal, all have issues. We know about some of these issues: metabolic syndrome, weight gain. They have their own problems, but they are less likely to cause the TD. So again, we're always trying to balance, trying to figure out what presents the most risk and what will provide the most benefit given for every specific case. So more research is necessary, right? Thinking about all the other theories, could there be a way to develop products through GABA or through glutamate or through serotonin? Who knows? Maybe that may happen in our future. But right now, the medications that we have are just those 2 that we talked about, the tetrabenazine and the Ingrezza. Those are the 2 that we have that are FDA approved for the treatment of TD. And both medications are based off of the fact that TD is thought to be as a result of the upregulation of dopamine, and those medications are trying to keep dopamine low so that those super sensitive receptors responding to the dopamine. That is my talk. So I'll take questions.
I don't know if it's a question or I want a little bit more elaboration. I have a neighbor who has 5 years with Parkinson, and she recently started in her sleep throwing things. So now, she lives alone, but now she's concerned that, that she might need to be restrained or something, or have somebody live with her. But she recently threw something heavy on the wall, and when she woke up, it was like a dent on the wall. So I hear her talk a lot about dopamine, and because I think that. So I don't know what do you have to say about that?
So without knowing all the details, right? Just jumping at the fact that that person has Parkinson's. So Parkinson's is kind of like, dopamine is on the low side, right? So I'm assuming that her treatment probably involves like a dopamine replacement, basically.
Oh,
And that, yeah, and that perhaps, again, without knowing to
yeah.
any extra details, perhaps
Oh.
all that dopamine is, making her more agitated, more aggressive, and who knows if she's even having psychotic experiences. It's possible.
Mhm.
Yeah.
Mhm. Okay.
I have a question. I have my son on Astero.
Yes.
Okay, he's been on it for like a
Sorry, can you
month
start
now.
over? I think I lost you for like a moment. Can you start over?
Oh, okay.
Sorry.
My son is on Astero, and he got diagnosed with Tardive Dyskinesia like about a month ago now, and he
Okay.
did have those movements. Well, he still does them, but not as much with the medication. But the
Okay.
only thing that I noticed that is that he it has side effects on him on his mood swings. Um his mood kind of changes a lot. Is that one of
So he got on Austedo about a month ago.
Yes.
And in the last month,
They still have him on. He's still on the. They're still testing him with that one to see how he does.
Okay, but in the meantime, you've noticed a worsening of his moods, like he has more mood swings. Okay, was any other medication changed?
No. They changed all his medications, but they had him hospitalized for them to accommodate all the psych medications and everything. He's in
So I guess my question, okay, so Carla, my question is the only new thing is it just the addition of Austedo, or was there changes made?
No, just the Austedo. And I noticed the difference with him that sometimes he gets like, he's really happy. Sometimes he's like, kind of like crying. And sometimes he's just like upset, I noticed the mood swings.
I mean, it's likely that the new medication, might be responsible for that. But I would definitely keep maybe a journal. You're noticing it and when it's happening. And I would, request to have an appointment. When are you supposed to have your next follow-up appointment with the doctor?
Yeah.
When do you have?
He's going every 2 weeks right now.
Okay. Yeah, I mean,
yeah, because they started him with 6 milligrams and then he went to 9 milligrams and right now he's at 12 milligrams.
Okay, yeah. If you think about, even with this lecture that we talked about how, yes, we think that with this medicine, this is what the predominant neurotransmitter is, but our brains are not like, isolated like islands, like all these systems are interconnected, right? So I would imagine that during this adjustment period that, there could be interactions with other medications that he's taking. There could just be the fact that neurotransmitter relatively are changing in dimensions too. So, but I would be, patient, but I definitely would encourage you to keep like a journal that has the specific mood swings and how you notice them and the usual triggers, to see if it's something that is to the point that, one would want to make a change with the other medications. Maybe, I don't know if it's on mood stabilizers, maybe make some adjustments with that, but I would definitely keep a journal. And then, is he in therapy as well?
Yes, they got him on therapy too. And, well, he was hospitalized for a while.
Therapy should okay. Yeah. And then, yes, the therapy should also be working on more coping skills, new techniques, new tools to help, to help him.
How old is your son?
27.
Okay.
And he just got, he just recently got diagnosed with probably like about on February.
Oh,
yeah.
Okay. Wow.
That's when I noticed
And
the
he's never been
movements.
He had never been on medications like psychotropics in the past.
Yeah, he was on he was only on the haloperidol, the Haldol shot for 9 years, because that was the only one that he was
When? When was
stabilized
the
with
first?
that one. He was on it for nine years on it. And then after that, he
Okay.
started developing, they tried to change his medication for a while, but they seen him that he was stable on that one, on the Haldol. So, and then after that, it wasn't working for him anymore. And that's when he developed that one. Right now, they got him in amantadine. And also he has the, what's the name of it? Divalproex sodium.
Divalproex?
Yes.
Divalproex?
Yes.
Okay.
And also he's on the other one that he takes for the night sleep, but it's also psychotic. It's the, oh my God, what's the name of it? You mentioned it earlier.
Seroquel?
Seroquel, yeah. He's on that one right now. So those are the three, I'm sorry.
Yeah, no, go ahead. I'll say what I need to say later. Go ahead.
Those are the 4 medications he's mainly on right now.
Okay. Yeah, I would look at other ways, like have the therapist teach him techniques, skills that can help him cope better with his mood swings. I would keep a detailed journal of what you noticed, the triggers, even things like if he slept well like the night before, what's his appetite like, those types of things. When is he happy? When is he sad? Things like that, like in details, so that one can use those.
And right now, he's dealing with like when we go out in public, he doesn't want to go around people because people stare at him when he makes a lot of the movements. So we have a really close relationship. We talk really good, and I let him know that it's okay if he does that, even if he says I try to control it, but he's still like, sometimes he just like, I think when he gets anxiety, he does it a lot, and even if he doesn't try to do it, but it's just, yeah. And his eye blinking, it's like at one point it was like they even that's when they sent him to see a neurologist because they thought there was something wrong with his vision. Yeah. Mm-hmm. Because he was blinking so much that they thought it was hurting him.
I suspect that he probably got TD like a while back, but and perhaps it wasn't picked up early enough.
Yes, that's what they say.
Yeah,
because he didn't make the movements at all. Before he didn't make the movements at all. It just started like on February when he started making the movements.
And sometimes it's just the blinking or the lip smacking. It's like simple things, but initially people don't notice, but and then it gets worse. Yeah, but I would definitely encourage the therapist to work with him, whether it's even the anxiety that he has in public places, just to help him in and other also, psychosocial ways.
Yeah, and they have him on vitamins. They put him on vitamins too. Vitamin, they have him on fish oil, vitamins from A to C, and then they got him on what is it that I have it right here. It's on vitamin E. That's the 3 vitamins they got him on right now for that too. So that way it can help them. They say that maybe they still can, I guess he's like under 30% that they say that he still can be controllable, because it's still like, I guess, in an early age,
Mhm.
which I don't know if it is
Yeah.
because I feel like he does the movements like a lot.
Mhm. Well, yeah, I say give it time, especially with the adjustments in, in the do the ostedo and give it time.
Yeah,
Okay.
thank you.
Thank you for sharing.
Can alcohol cause those problems? My brother-in-law does a lot of things with his mouth, and
Say that again.
can alcohol cause those kind of problems?
Well, alcohol has its own movement issues as well, like tremors, tremulousness, and all kinds of movement issues. But it's not what we're describing. But it does, yeah. Alcohol disorder could be associated with movement issues.
Okay.
Yeah.
I have a question on some of the older antipsychotics
you.
like Thorazine. Would that be one when people were on that they used to get that they would
The shuffle.
Mhm.
So I think it's more descriptive of Parkinsonism, right? Because even people that have Parkinson's have that shuttle, not shuttle, shuffle. So I would think that if one is talking about shuffling, that one is looking at more like at Parkinsonism, right? Which is separate from TD, which is a different type of movement disorder or extrapyramidal effect. That is more typical of that imbalance with the seesaw that we talked about earlier on. Yeah. And so the treatment is separate or different from TB.
But Thorazine is a first generation, right? Antipsychotic. Is Thorazine a first generation antipsychotic?
It is first, yes. Thorazine is first generation. So
Yes.
same class as Haldol, the ones that are more likely to cause it.
Yes.
Yeah.
Okay. All right. That was my question.
Yeah.
'Cause my mom was on Thorazine years ago, but that was all they had.
Mm-hmm.
I think it's because Thorazine is same as chlorpromazine. Let me see. I think it's because that chlorpromazine is our oldest antipsychotic. Let me see. I think Thorazine is the same as chlorpromazine. Yes, it's chlorpromazine. So it's the earliest. It's our oldest antipsychotic. I want to say it was 1950s.
Mhm.
It was discovered in, I know it's like in the 50s.
Mm-hmm.
History. Yeah, by the 50s we had them. Yeah, by the 50s, yeah, we had them. Yeah, it was distributed for testing to physicians between April and August of 1951. So yeah, it's our oldest antipsychotic. Yeah.
Everything that you're sharing, doctor, brings me memories when I started an internship as a substance abuse counselor at the adult mental health clinic. And I remember being a facilitator for a group, and most of the clients there always had some kind of movement in their lips. And they did have psychotic episodes and features, but one of them stuck out his tongue, like back and forth, back and forth. I felt so bad for him, like he was going to catch flies. And it was so everything that you're saying, I wish I would have known it back then, because I could have been more understanding. I didn't know a whole lot about it, the movements that they made with their mouth and sucking their lips. And so we always had candy for them in the table. So to kind of help with the impulsiveness and the chewing of their lips and all of that. So yeah, I didn't know there was a name.
Yeah, right.
I mean,
yeah, but those movements, right? They were not like, they weren't trying to be impulsive, actually, right?
yeah,
They couldn't control It
They
was just
couldn't.
happening out of, they were vodka
Yeah, oh,
volunteering.
yeah,
Yeah.
yeah, uh-huh.
Yeah.
That's what everybody would say, it's the medication, it's the medication. But, you know, back then I didn't
Yeah.
know, but there's a name for
Yeah.
it. It's what you just mentioned. It's,
Yes.
they
And then
have
if you think about the
okay.
fact that, we had Thorazine since 1951, right? It says that physicians
Mhm.
started using it by 1950. It wasn't until 2017, right? Just 5 years ago that we got FDA approved medications. So everything anyone was doing in the past was just like, okay, maybe anticholinergics
Yeah.
work for the dystonia, let's try. Or we use this for chorea, let's try that, So we didn't have
Yeah.
FDA approval. So imagine, like for the 70 something years, like our patients have just just been suffering.
Yeah.
Yeah. So
It's
so
sad.
so the good thing about science, as we
I have a kind of an off
I don't know what
topic.
happened.
We still see you.
I have kind of an off topic question.
Okay.
What are your thoughts? My son was on esketamine for a while and he felt like it was real positive for him. He's gotten off all his medication. He was on a variety of different things. He's doing well, but he's still very depressed. What are your thoughts about esketamine?
So that's one that just got the FDA approval not too long ago. But there's certain people that I've met, some of my colleagues that use it who swear by it, But I think that one important thing with every individual patient who struggles with whatever they struggle with is, right? So if the medicine is not enough, or let's not say it's not enough, if the medicine is not bringing up the desired outcome, we need to go back to the drawing board. Sometimes it might mean that he's on esketamine and maybe something else. Maybe he needs something else to help make it better. But I just feel like we don't, like when we talk about clinical trials and just throwing out numbers, we're just talking about whatever, right? We're not talking about anybody. But when we're talking about who is struggling with a specific disorder, then we have to personalize it. So I would encourage you to go back to that person who's prescribing it to really share with them the difficulties that they're having. Because there's always ways. There are a lot of people who just don't do well on one attacking a disorder from one mechanism. Like a lot of times you may have to do different mechanisms. So like Carla was sharing about how her son is not just on the medicine, the Austedo that was released in 2017 or approved in 2017, 2018, but he's also on like vitamins, so they're trying to see if there could be like regeneration, or he's on a vitamin E, right, which is an antioxidant. So, could it be oxidative stress? So it's always best to think about any disorder as having many possible options, of many possible ways that we can get to recovery, and try to use as many of those as possible. So, making sure he's in therapy, making sure that he's doing, other things that he likes to do, keeping him active, keeping him doing meaningful, being meaningfully engaged in activities that he likes, being on that medication, maybe supplementing or complementing with something else, is what I would say. So I think, do we have any more questions?
Well, thank you everyone for attending. Thank you, Dr. Ijeaku, for your talk. And is it okay if we share your PowerPoint?
That's fine.
Okay, so I will share the PowerPoint with you all and I will send out a recording, YouTube recording of the talk. Give me a few days to get all that together.
Okay, thank you.
Okay,
Okay,
thank you.
Good night.
Thank you. Have a good night and thank you.